Okay, the next video starts with thalassemia inherited anemia. So thalassemia is a hemoglobinopathy resulting from defective synthesis of the globin chains required for hemoglobin synthesis. Each copy of chromosome 16 has 2 genes for the alpha globulin subunit, 4 in total, and each copy of chromosome 11 has 1 gene for beta subunit. So 16 alpha and 11 beta. 2 in total. Adult hemoglobin HbA1a alpha to beta, second adult hemoglobin HbA2, and fetal hemoglobin HbF. So this is the main one. And the second one is this, and fetal one is that. So alpha thalassemia is due to deficiency of alpha chain in the hemoglobin. 2 separate alpha globin chain genes are located on each chromosome 116. Clinical severity depends on the number of alpha chains present. If 1 or 2 alpha chains are absent, then the blood picture would be hypochromic and microcytic, but the hemoglobin level would be typically normal. Loss of 3 alpha chains result in hypochromic microcytic anemia with splenomegaly, is known as HBH disease. If all 4 alpha chains are absent, then death in utero, hydros fetalis, occurs. So it's alpha thalassemia again. 1 gene deletion silent carrier, 2 gene deletion alpha thalassemia trait, 3 gene deletion hemoglobin H disease, B4 moderate anemia splenomegaly, and 4 gene deletion Bart's hemoglobin hydrophysalis. This is for alpha thalassemia. Then beta thalassemia are due to mutations in the HBB gene on chromosome 11, also inherited in autosomal recessive fashion. So this one was also autosomal recessive. AR, if you remember that, AR. This one is also AR. So the severity of the disease depends on the nature of the mutation. Mutations are categorized as BO or beta thalassemia major if they prevent any formation of beta chains, which is the most severe form of beta thalassemia. If they allow some beta chain formation to occur. In either case, there is accelerated excess of alpha chain, but these do not form tetramers. Rather, they bind to the red blood cell membranes, producing beta membrane damage, and at high concentrations, they form toxic aggregates. So here again, we are coming to the deletion numbers. 1 gene deletion, beta thalassemia minor. So 1 gene deletion, beta thalassemia minor, mild anemia, microcytosis, elevated HbA2. Remember that. 2 gene deletion, beta thalassemia major, anemia when HbF tries to convert to HbA during first year of life. Extramedullary hematopoiesis will be there, hemopoiesis with hepatosplenomegaly, bone marrow expansion, hair on end appearance of bone, hair or end. This is for beta thalassemia. So yeah, 2 gene deletions. So if you remember, the main thing is there are like 4 alpha chains, 4 beta chains, and alpha thalassemia is like 4 gene deletion would be hydrophysalis, 3 will be like moderate anemia, HbH disease, 2 gene deletion would be microcytosis, and like anemia decrease HbA2, 1 gene deletion silent carrier. And for beta 2, there are 2 beta 2, so 2 gene deletion will be made by beta thalassemia major with all these manifestations of hepatosplenomegaly, bone marrow expansion, hemopoiesis, hair on an appearance, and then mild beta thalassemia minor. 1 gene deletion will cause mild anemia, microcytosis, HbA2 elevated, and this one will be decreased for that. Okay. There's another one called delta thalassemia, in which as well as alpha and beta chains being present in hemoglobin, just 3% of all hemoglobin is made up of alpha and delta chain. Just as with beta thalassemia, mutations can occur which affect the ability of this gene to produce delta chains. Thalassemia can coexist with other hemoglobinopathy. The most common of these are these: hemoglobin E, hemoglobin S, hemoglobin C. So it's in Cambodia, Thailand, parts of India. This one's African as well as whatever. You don't need to know that much. Okay, moving to the next important topic is sickle cell disease. Is very important. The sickle cell crises and all those things, you need to know that very well. So sickle cell disease is characterized by periods of good health with intervening crises. So it's inherited as an autosomal recessive once again, and it's caused by mutations in the beta globin chain of hemoglobin, causing hydrophilic amino acids, glutamic acid, to be replaced with hydrophobic amino acid valine. So this mutation in beta globin chain, whereas glutamic acid is replaced by valine. at the sixth position. So you see here in chromosome 6, right? Now, at the sixth position, the beta-globin chain is found to be on the short arm of chromosome 11. The association of two wild-type alpha-globin subunits with two mutant globin units form HBS. So, we need to know. Sickle cell anemia is a specific form of sickle cell disease in which there is homozygosity for the mutation. It's also known as HBSS, SS, or HBS. Just that. Heterozygous, one sickle gene and one normal gene is known as HBAS. So this is like sickle cell trait, not the disease. The disease is HBSS, or it is just this. Other rare forms of sickle cell disease include sickle hemoglobin C disease, sickle beta plus thalassemia, and sickle beta zero thalassemia. All these things, these are other forms of sickle cell disease and are compound heterozygous states in which person has only one copy of the mutation that causes HBS and one copy of another abnormal hemoglobin allele. So if you remember what glutamic acid replaced by valine, it's happening in chromosome 11, and heterozygous would be HBAS and homozygous HBSS. And then the very important part is the crisis. The four types of crisis are there in sickle cell disease, like thrombotic, painful crisis, aplastic, sequestration, hemolytic. So thrombotic crisis is also known as painful crisis. Thrombosis is painful. Or vaso-occlusive crisis, precipitated by infection, dehydration, deoxygenation. So all these things can precipitate thrombotic crisis. Infarcts occur in various organs, including the bones, avascular necrosis of the hip, hand-foot syndrome, and children, lung, spleen, brain as well. Okay, so this painful crisis, infarcts can occur. Aplastic crisis caused by infection with parvovirus and sudden fall in hemoglobin. So this is something this keeps on coming in the exam. Sudden fall of hemoglobin. So which stage is it? It has to be aplastic crisis, and it's caused by parvovirus infection. Sequestration crisis is when there is like organomegaly, sickling with an organ such as spleen or lungs, causing pool of blood with worsening of the anemia. So there is pooling of blood and the sickling within the organ, spleen or lungs. Acute chest syndrome can occur in sequestration crisis. Like dyspnea, acute chest syndrome, dyspnea, chest pain, permanent infiltrate, low oxygen saturation. The most common cause of deaths in adults is this acute chest syndrome. So this is something very important. So hydroxyurea reduces the incidence of acute chest. So hydroxyurea can be used. So this is something extremely important. Cause of death can be acute chest syndrome. The most common cause of death in childhood: infarction and infection, pneumococcus, chlamydia, and mycoplasma. Then there is a hemolytic crisis, which is rare, and falls in hemoglobin due to increased rate of hemolysis. So some things to be recalled here: aplastic crisis, like sudden fall in hemoglobin caused by parvovirus. There is painful crisis where there is like infarction, infection, which can promote that. And sequestration crisis, there may be pooling of blood in the organs like spleen or lungs. Acute chest syndrome happens here as well. Dyspnea, chest pain, pulmonary infiltrates, low oxygen. So all these. Hydroxyurea decreases the incidence of acute chest syndrome. Okay, moving to the next important topic. Hereditary spherocytosis, also very, these two are always there, T6PD and spherocytosis. So most common hereditary hemolytic anemia in the North Europeans, and autosomal dominant. Unlike the other diseases we've seen so far, most of them are autosomal recessive. This is autosomal dominant defect of the red blood cell cytoskeleton, and it's like biconcave disc spherocytes. Red cell survival decreases, destroyed by spleen. So basically it happens everything in the spleen. So that's how spherocytes happen. So presentation can be failure to thrive as red blood cells are decreasing. Jaundice and gallstones, splenomegaly is obvious. Aplastic crisis precipitated by parvovirus infection. This can also previously we've seen there in sickle cell as well. Variable degree of hemolysis, MCV decrease, and increase MCHC, increase reticulocyte. So something important. So what you do is osmotic fragility test. So I think this one is replaced by something new. You have to check it out as well. Osmotic fragility test for hereditary this is replaced by something new. Definitely, this was the previous one. Now it's something different. We'll just mention it in the next. Okay, so the new guidelines say this is the old diagnosis. Now it's EMA binding test, which will help you diagnose hereditary spherocytosis, and management will be followed replacement splenectomy. Spherocytosis gives rise to chronic hemolysis and gallstone formation. An important differential in a patient with hereditary spherocytosis will be a splenic rupture. Okay. So G6PD deficiency as well is there as the commonest red cell enzyme defect, and it's more common people from the Mediterranean Africa as well as that. It's X-linked recessive, and many drugs can precipitate a crisis as well as infection and broad fava beans. So neonatal jaundice is often seen. Intravascular hemolysis is there. Haynes bodies on blood films, and this made by G6PD enzyme assay. And drugs causing hemolysis can be ciprofloxacin, is always studied this. Antimalarial like primaquine can also cause it. Sulfonamide, trimoxazole, sulfa-containing drugs can be dangerous for G6PD. So it can cause hemolysis. Okay, so red cell enzyme defect, that's what you have to remember. And safe drugs are penicillin, cephalosporin, macrolide, tetracycline, trimethoprim. These two even often comes in the exams, so if you remember that. And this is often presented in childhood. And this is also intravascular hemolysis in these bodies. The red ones are the ones you have to remember like even better. It's Haynes bodies in blood films. Okay, less commonly popular leukoerythroblastic anemia. It's basically left-shifted granulocytic series and nucleated red blood cells with pancytopenia. Also defined when there are immature cells like myelocyte and nucleated red blood cell seen on the peripheral blood film. So left-sided granulocytic series, and okay, association can be this. You see multiple lobes. Bone marrow increased bone marrow turnover and severe hemolysis, myelofibrosis, CML, bone marrow invasion. Often in the bone marrow invasion, the invading malignancy will already have been diagnosed previously. Myeloma, polycythemia rubra, osteopetrosis, tuberculous infiltration of the bone marrow, sarcoidosis. All this will be the association. Okay, now moving to the hemato-oncology section, there's more to it, and we'll have ALL, CML, all those raised diseases. So firstly, myelofibrosis, it's a myeloproliferative disorder. Overview, thought to be caused by hyperplasia of the abnormal megakaryocytes. Okay, remember that, platelet. So thought to be caused by hyperplasia of the abnormal megakaryocyte bone marrow cell responsible to produce blood thrombocytes like platelets. So this is the one which ultimately becomes platelet. So it's hyperplasia of that. The resultant release of platelet-derived growth factor is thought to stimulate fibroblasts. So fibroblasts increases, and hematopoiesis develops in the liver and the spleen. So the liver and the spleen starts producing blood cells as well. So hyperplasia of the myokaryocyte, increased platelet-derived growth factor, stimulate fibroblasts. So this fibrosis, myelofibrosis, so fibroblast, remember that. And then features can be elderly person with symptoms of anemia, fatigue, massive splenomegaly, because these are producing this is causing hematopoiesis in spleen and liver. Hypermetabolic syndrome like weight loss, night sweat. Okay, findings can be anemia, increased white blood cell and platelet count early in the disease. So there will be increased white blood cell, teardrop, poikilocyte on blood film. Also important, teardrop, poikilocyte. Unobtainable bone marrow biopsy, dry tap, therefore trephine biopsy needed. Increased urate and LDH, reflecting this cell turnover. So fibroblast increase, and then increase of platelets. But anemia and can happen, and white blood cell and platelet count increases early in the disease. Teardrop, poikilocytes and blood film. Remember that. So all these things that you remember. Myelodysplasia, what is this? Occurs mainly in the elderly, and 30% transforms into AML. Okay. Presentation will be anemia, infection, bleeding due to pancytopenia. So investigation is serial blood counts show evidence of increasing bone marrow failure. Bone marrow shows increased cell variety. Management is less than 5% blast in the bone marrow. Managed conservatively. This increased white blood cell give general chemotherapy. Less than 60-year-old intensive chemotherapy. So not much to remember from here. Okay, coming to the main blood cancers, the thing that we call. Actually, myelofibrosis is also a disorder under hemato-oncology. So all these disorders, CML, always are coming up. Lots of disease. Okay, so first one is CML. CML is like basically chronic myeloid leukemia. So the Philadelphia chromosome, as we know, is present in more than 95% of the patient's CML. Is due to translocation between the long arm of chromosome 9 and 22, and it results in the part of ABL proton genes from chromosome 9 being fused with the BCR from chromosome 22. So this is ABL BCR. The resulting BCR ABL gene calls for a fusion protein which has tyrosine kinase activity in excess of normal. So excess tyrosine kinase activity. So this is the main reason behind this problem. Fusion of BCR-ABL and causing increased tyrosine kinase activity. So of course, what do you want to give for the treatment? Tyrosine kinase inhibitor. So presentation can be middle-aged people can have that, and the anemia and weight loss, splenomegaly. Okay, splenomegaly might be marked like lethargy, anorexia, abdominal discomfort, 75% palpable spleen, hepatomegaly, and lymphadenopathy are uncommon. Like splenomegaly is the main one. So spectrum of myeloid cells seen in the peripheral blood. So myeloid cells will be seen more, and decreased neutrophil alkaline phosphatase. It may undergo blast transformation as well. So myeloid cells are more there, may undergo blast transformation. AML in 80%, AL 20%. So diagnosis Philadelphia is confirmatory. So you see the chromosome, you know that it's this CML. Now peripheral what you will see leukocytosis. So white blood cell will increase in all stages of differentiation within the myeloid lineage. And basophilia is important diagnostic marker, especially when Philadelphia is absent. Monocytopenia, bone marrow hypercellularity with myeloid erythroid ratio. So you know the myeloid lines, so all these may increase, especially the white cell leukocytosis. Granulocytes of all types. Increased granulocyte of all types typically include mature myeloid cell, basophil, eosinophil are almost universally increased. This feature may help differentiate CML from a leukocyte reaction. So leukocyte reaction also has similar features. So how can you differentiate? So basophil, eosinophil are almost universally increased. And this feature, okay, so these ones are also increased in white blood cell. In CML. Bone marrow biopsy is often performed as part of the evaluation for CML, and CML is confirmed by detecting the Philadelphia chromosomes. This can be detected by the routine cytogenetics, by fluorescent in situ hybridization, or by PCR for the B cell. So you can do this routine cytogenetics for this chromosome, or we can do PCR for the BCR-ABL fusion gene. We can do both. The management can be imatinib, this is the one. Tyrosine kinase inhibitor, first line, very high response rate in chronic phase AML. Dasatinib, nilotinib, newer TKI. If you cannot have imatinib or the disease is imatinib resistant, you can try these. Ponatinib, positinib, all these. Hydroxyurea also used in PRV, painful attacks in sicklers, and also antiretroviral HIV. You can also use interferon alpha, or allogenic bone marrow transplant can also be taken place. It's the recommended method for after imatinib failure. 30% of patients will have HLA matched sibling who can act as a donor. So mortality and morbidity from this procedure may vary between 10 to 70%. Autologous stem cell transplantation may prolong survival but does not reduce mortality. There is no clear evidence on the benefits of autologous CT. So this T992 is good prognosis in CML, poor prognosis in AML. So this itself, translocation is good prognosis in CML. Okay. moving to AML, more common, the most common form of acute leukemia in adults. It may occur as a primary disease or following a second transformation of myeloproliferative disorder like CML or myelofibrosis. These can transform to AML. More than 30% blasts are almost diagnostic of AML. Okay, so presentation can be generally disease of older adults, median age at diagnosis between 65 and 70, so old people. More than 56 years, more likely to have unfavorable cytogenetics. Early signs are vague and non-specific. Influenza like persistent or infrequent infections due to decreased red blood cells. So this one is chronic. You'll see more white blood cell, like aging is staying there, and there is a lot of white blood cell. And for acute, you'll see like a lot of blast cell, and so there's decreased white blood cell, decreased platelet. There will be bruising and petechiae, frequent infection. There will be splenomegaly, lymph node swellings, rare, no need. CNS involvement at diagnosis seen in 50% patients usually manifests as leptomeningeal disease with headache and isolated cranial nerve palsies. Signs can be leukemia cutis, gingival infiltration, testicular involvement rarely. Symptoms are caused by pancytopenia. So you see all these things happen, and because there's blast cells, immature cells in the blood. The combination of the myeloproliferative oxidase or pseudo black stain and the non-specific esterase will provide distinction of AML from ALL and in classification of AML in most cases. Okay, management of AML. See. The management, the objectives of treatment is to produce and maintain complete remission. So want complete remission for that. This is the only currently accepted approach to AML cure. Hence, management is divided into stabilization of the actively vulnerable patient, induction, remission, post-remission therapy. So, how do you induce the remission? Okay, we've written some Ruby Citara, I don't know what's that. Induction using a combination of cytotoxic agent like anthracycline, daunorubicin, so there's the Ruby. Idarubicin is the Ruby, anthracycline or anthracycline and citarabine. So, Ruby Citara, that's the thing we wrote here. This will lead to myelosuppression and possibly severe infection. The patient may be treated prophylactically with antibiotics. So these are cytotoxic agents, so they can be followed by myelosuppression and severe infection. So prophylactic antibiotics will be given. So post remission, even after complete remission, very few leukemic cells likely to remain undetected with current diagnostic techniques. If no further post remission is given, almost all patients will eventually relapse. Therefore, more therapy is necessary to eliminate non-detectable disease and prevent relapse. That is to achieve a cure. The specific type of post-remission therapy is individualized based on prognostic factors and general health. For good prognosis, leukemia TA21 and T57 patients will typically undergo additional 3 to 5 courses of intensive chemotherapy. Okay, these two are a bit dangerous, as it says. For patients at high risk of relapse, those with high risk allogenic stem cell transplantation is recommended. What is poor prognostic features? More than 60 years, old people, okay, bad, and more than 20% blast after first course of chemo. So still having a lot of blast cells. Cytogenetics, deletion of chromosome 5 or 7. This comes in the exam a lot. Poor prognosis. So poor prognosis, more than 60-year-old, more than 20% blast even after the first session of chemo and course of chemo, and cytogenetics, deletion of 5 or 7 chromosomes. Can be bad prognosis. Poor prognosis. So let's know more about AML. So the classifications are not really necessary to know, but then you need to know the third one, M3 APML. So you're not expected to, as I said, the exception is to M3 subtype. The importance of identifying APL is in both the presentation, classical DIC and management. So APL is associated with the T1517 translocation, which causes fusion of the PML RAR genes. Important. So associated with T1517, as I already said, fusion of PML RAR gene, already said, presence younger than other types of PML, average is 25 years, so that's dangerous. Good prognosis is curable. Chest infection, increased WBC or DIC or thrombocytopenia often at presentation. So DIC can be a presenting factor. Treated with ATRA and chemotherapy. ATRA is all transuranic acid. Activates alpha gene, helps WBC to mature but will not eliminate leukemia. So it helps to mature instead. Like the blast cells will mature. Okay, treated with ATRA chemotherapy, anthracyclines, as we've said before previously, the rubies and the sitaras. Um, so care must be taken to prevent DIC, complicating the treatment when the promyelocytes release the content of their granules into the peripheral circulation. Okay, and now the diagnosis. You can see the air rod. It's an eosinophilic needle-like inclusion here. Inside of the blast cell is pathognomonic of AML. Air rods. Okay, diagnosis. The first clue is an abnormal FBC. While increased WBC is a common finding and leukemic blasts are always sometimes seen, AML can also present with isolated decreased platelet, decreased RBC, and even decreased red blood cell. While a presumptive diagnosis of the AML can be made via examination of the peripheral blood smear when they are circulating leukemic blasts, a definitive diagnosis usually requires an adequate bone marrow aspiration biopsy. Bone marrow is a must. So usually AML is giving pancytopenia, and there will be a lot of blast cell immature cells, and compared to CML where there's a lot of white cell which are over mature. And for AML there's M3 type, which is very important, which may present with DIC and increased WBC and all that. Or also they have poor prognostic factors, I've said already. And the treatment will be danirubicin, citrabine, and all these things. Okay, CLL, chronic lymphocytic leukemia. So every disease has some sort of clue as to what to expect from it. So CLL is it's caused by monoclonal proliferation of the lymphocytes, well differentiated lymphocytes, mature lymphocytes, which are almost always B cell. So it's always about B cell. CLL is always about B cell. So often none features, 70% diagnosed incidentally on FBC. So constitution, anorexia, weight loss will be there. Bleeding infection, lymphadenopathy more marked than CML, so there's lymphadenopathy. And then complications can be hypogammaglobulinemia leading to recurrent infection, most common cause of death. So gammaglobulinemia, hypo. Warm autoimmune hemolytic anemia into some patients, transformation to high-grade lymphoma can also be happening there. Immunophenotyping, flow cytometry, cleftin smear or smooth cells. CLL is immunophenotyping is the best investigation of choice, and immunophenotyping will demonstrate the cells to be B cells, CD19 plus or CD5, CD25. All three are quadrilaterally positive. 5, 19, 33. Okay. Indications for treatment. So binary stage A patients. Binary staging. Less than 3 lymphoid areas, more than 3 lymphoid areas. All these. Generally do not need treatments. Binary A. Stage A who develop AIHA or ITP in presence of absence of disease progression should be treated as autoimmune phenomena. Binary stage A and B if they have progressive decreased hemoglobin or platelet, not autoimmune. Lymphocyte doubling time less than 6 months. So this is indication for treatment. So when stage A and B with this all these things, lymphocyte doubling stage less than 6 months, lymphadenopathy, systemic symptoms, or AIHA, ITP. Stage C with decrease all that, initial treatment. So sometimes they'll be coming up. There are 5 lymphocyte areas for the purpose of classification: cervical, axillary, inguinal, lymphoid, hepatosplenomegaly, all these. RAI staging uses 0 to 5 stages, where 0 and 1 are low risk group, 2 is blah blah blah. Okay, so what do you use for CLL? Incidental finding, as I've said, none early on, so there's no treatment at first. Treatment is tailored according to stage and immunophenotyping. You are not expected to know the regimens in detail, but you must be aware of options and possible side effects. Okay. Purine analogs can be used: fludarabine, cladribine, and pentostatin. So fludarabine, because fludarabine causes profound lymphopenia, increased risk of infection significantly, you must give cotrimoxazole or use Monthly nebulized pentamidine to prevent pneumocystis carrying pneumonia. Okay, you can use fludarabine. Combination in chemotherapy of fludarabine and cyclophosphamide has been proven to be superior than fludarabine alone. So can we use cyclophosphamide as well? So flu in a with the cycle. Monoclonal antibodies rituximab in combination with fludarabine and cyclophosphamide is recommended as an option as well. It's a chimeric monoclonal antibody that binds selectively to CD20 antigen exposed on the surface of Mrcp lymphocytes and tumor cell. Alemtuzumab, humanized monoclonal antibody which binds to CD52, has been shown to be effective in treatment of patients with poor prognostic features, patients with high-risk cytogenetics. All these alkylating agents can be used, like chlorambucil decreases lymphocyte count, and when combined with prednisolone is associated with an initial response of 60 to 90%. Okay, complete response to 20%. Cyclophosphamide usually can be used with bendamustine, allogeneic stem cell transplantation, only curative therapy, splenectomy. All this can be used. Very difficult topic actually. And poor prognostic factors also to remember. Male sex, age more than 70 years, or CLL. Lymphocyte count more than 50. Doubling time less than 12, less than 1 year. Pro-lymphocytic comprising more than 10% blood lymphocyte. Raise LDH, CDX 38% positive. All these poor prognostic features.